Hi, this is Brian Kim. I'm going to share with you this case of a patient who has a corneal transplant. It's a little bit on the hazy side, and she also has a cataract now. And so I'm going to show you how I'm going to disassemble this lens under poor visibility. And I'm going to just highlight and show you how mechanical fracturing techniques really shine under these situations. So again, this is a patient who has a corneal transplant, again, a hazy cornea. I'm going to use a corneal marker, which will help me to center and size my rhexis. And I'll make my incisions here. First on the right side and the left side, making sure that I'm flat to the iris plane, but also making sure that it does not abut the graft incision line. So you'll want to go in, but make sure you enter before you get to the graft edge. I'm going to inject some intracameral lidocaine and then some intracameral epinephrine. And then we're going to inject some intracameral air and then some trypan blue. And I like to paint the surface of the anterior capsule rather than flooding the eye with the dye. And I like to just gently paint the anterior capsule surface with the cannula, just like I'm using a paint roller to roll paint on a wall. I'm using the cannula to roll the dye on the anterior capsule surface, minimizing exposure of the dye to the corneal endothelium. Going ahead and injecting some dispersive viscoelastic and pushing it in such a way that the bubble comes out. And with the incision, I could see that there's quite a bit of fibrosis on the edge of the graft, and so I'm not really worried about a dehiscence of the wound. And there's quite a bit of distance between the limbus and the graft edge, so I decided to go ahead with a limbal approach rather than a scleral tunnel. So this is a triplanar corneal incision. I make a vertical groove, tunnel through the cornea, and then enter. I'm pushing some more viscoelastic now. And so this is the puncture style rhexis, using the forceps to puncture the center. This patient is fairly young, and so I could tell that the capsule is a little bit elastic and it wasn't able to puncture. And especially since the visibility is not great, I decided to switch to a cystotome. I'm asking my assistant to irrigate the cornea to help me see for a moment. I cut and sweep to the left and then create a flap. So once the flap has been made, I'm going to go in with the forceps again, and I'm going to go around. And the trypan blue really helps my visibility with this case. You can see the rhexis is very clearly seen here. I'm just going around circumferentially. Again, this lady is fairly young. She had an injury at a young age, and so I do think this lens is not going to be that dense, but we'll see. But again, mechanical fracturing is really a fantastic technique for this, and when you have poor visibility. This is capsular fornix hydrodissection technique. I place the cannula out underneath the rhexis edge contra-incisionally. I push and then get a nice wave. I can tell this is a really soft lens. I try to decompress, but it's just kind of cheese wiring. It's not really doing much. And so I just switch to phaco quickly, irrigate the cornea, make sure the position of my sleeve is adequate the way I want it, lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. Whenever visibility is bad, you never want to use phaco or vacuum, because if you do that, you can, especially near the posterior capsule. And so you can see I did the double chop and the cross chop. Again, this lens is fairly soft. The visibility is not very good. The benefits of double chop and cross chop in this situation is you don't have to have very good visibility, and you can still divide the lens with confidence and with safety. Why? Because you're using the instruments to cut the lens. Under poor visibility, if you're sculpting or if you're lollipopping the lens, you're using either phaco or high vacuum, And you can get close to the posterior capsule when you do these things. And when you have poor visibility, you might rupture the posterior capsule. And you don't have to worry about any of those things with these techniques. You're just doing mechanical fracturing forces. Again, you're basically crushing the lens and sandwiching it between the chopper and the phaco tip. And as long as you are in good position with your instruments, you're within the capsular bag, you're not, even if you're near the posterior capsule with those maneuvers, you're not using vacuum or ultrasonic energy. So it's very, very safe. And as long as you stay within the plane of the lens and you're not going too deep with the instruments, you're not going to rupture the posterior capsule. And so you can see even the visibility is not great. I'm able to use mechanical fracturing forces to crush the lens pieces into smaller pieces, manipulate the pieces in such a way that I can position the lens piece around my instruments and then crush the lens piece. And so essentially I was doing that throughout the entire case, despite not great visibility and despite the fact that the lens just seemed like it was just this amorphous mass. But ultimately I'm able to break it up and remove it. Again, very confidently, very safely, despite poor visibility. Now that the lens is out, I take the chopper out, push BSS in, take the phaco tip out, and go in with the INA handpiece. There was a small nugget there that I was able to eat with the INA tip. I start subincisionally grasping the anterior part of the cortex, sweeping side to side to peel it off from front to back. So I'm staying in the subincisional position. There's still some more material there. Sweeping side to side, getting occlusion, and peeling it off. And the polymer tip during this step is just really wonderful because it gives me so much confidence. Again, this disposable tip is very, very safe. I'm able to get underneath the rhexis edge very confidently and safely, removing the cortex. I switched to polish mode now that the cortex is out, and I'm just polishing under the rhexis edge to remove any potential remaining cortical material as well as the lens epithelial cells. And as I do this, small wisps of cortex are able to come out. Again, even though the view is poor because of the PKP, it doesn't really matter. I feel very confident that it's safe. I'm able to sweep even though visibility is poor. Again, because of the polish mode, it's such a very, very delicate, low flow situation. And as long as you're moving very slowly, this is really very safe. So once I'm done with that, I'm just going to go in with the cohesive viscoelastic cannula and fill the bag. I don't have a good enough visibility to confidently place that cannula into the subincisional fornix to pulse, and I don't want to cause a problem. And so I do bypass that step because of the poor visibility here. And I'm going to put a 3-piece lens into the capsular bag in this patient, just in case there might be some weak zonules. I have to widen the incision for this lens. Go ahead and widen the incision with the diamond blade. Go in with the injector, have the bevel pointed to the left. The leading haptic will come out planar, pointing to the left as well. It's going in as it's advanced into the capsular bag. As the optic is delivered, I rotate my hand towards the left counterclockwise, and the optic comes out flat. You want to leave the trailing haptic out, pointed to the right. I use a Maltzman then to very carefully dial the trailing haptic into the bag. So I go in with the INA handpiece, activate irrigation. Once it's activated, I can go under the lens safely and then remove all the viscoelastic from within the bag underneath the lens. And then remove the viscoelastic from the anterior chamber. So again, mechanical fracturing techniques are really very powerful because you're leveraging your instruments, and you can very carefully and very precisely break up the lens pieces, since you're using both of your hands, the chopper as well as the phaco tip, to crush the lens piece. You're not having to rely on ultrasonic energy. You're not relying on sculpting. You're not relying on lollipopping the lens, impaling the lens for chopping maneuvers. You don't have to utilize high vacuum or ultrasonic energy. Again, whenever you do those maneuvers near the posterior capsule under poor visibility, it can be quite intimidating. And again, although you probably will and can do it very safely, compared to doing it this way, where this is really, there's no risk to the posterior capsule when you're doing mechanical fracturing techniques. And that is why, again, I've done all the standard techniques. I've done divide and conquer in my training, stop and chop, vertical chop, horizontal chop. I've done all the standard techniques. And this technique that I'm doing is not just some, small variant. This is really a paradigm shift in the way you think about cataract surgery. Because with all of those other techniques, the standard techniques, you have to heavily rely on the instrumentation to disassemble the lens. You have to rely on the phaco machine to disassemble the lens. And without relying on the phaco machine for those techniques, you're powerless to disassemble the lens. Whereas with this technique, as long as you have just active irrigation, you can get around the lens with the chopper. You can rotate the phaco tip vertically, subincisionally. You can crush the lens. You can scissor your instruments with the cross chop maneuver, crushing the lens and dividing heminuclei and small lens pieces. And by using mechanical fracturing techniques, you're able to disassemble the lens even though there's a poor view. And so this is really the main reason why I feel like it's such a really a versatile technique. So you can see my incision was very leaky, and that's because I was using the cotton tip, and as I was dabbing the incision, you can see it was leaking. And so I go ahead and put a single tenon suture in, but despite that, it kept leaking. And so now I'm going to put in a butterfly suture here. And so I'm going to pull out that central suture because it really wasn't doing anything. And then I'm going to go ahead and tie this one down. When I was training, I was told that we have to use a Wexel to check the wound, and that you were worried about, cotton fibers getting into the eye with the cotton tip. But, my partners have been using a cotton tip way before my time. And when I got to the practice, I started using a cotton tip too. I've never had a piece of cotton into the eye using a cotton tip. And I can very confidently tell that the eye is dry without a Wexel sponge or a Seidel strip, a fluorescein strip. I don't really need to have either of those things to confirm that I'm dry. And so you're going to see here what I'm talking about. When you wipe it with the Q-tip, it causes a glistening, a shiny silver line there. You can see it. See that shiny silver line on the incision? When you see that shiny silver line, that means you are dry. That is absolutely dry, stone cold dry. That is a Seidel negative incision right there. Again, you don't have to use a Wexel sponge or a fluorescein strip to check that. So I hope this case is a good example of why mechanical fracturing is so great. Again, under poor visibility, mechanical fracturing shines because you'll be able to disassemble the lens despite poor visibility. So mechanical fracturing is not just good to reduce CDE, but you can confidently disassemble the lens in the context of a cloudy cornea. So I hope this was helpful to you, and I thank you for your attention.